Welcome to Pathagonia. This is Jay. Today we're going to use Kurt's notes to talk about donor liver and kidney frozen section evaluation. Before we begin, if you already haven't, you've got to check out Kurt's notes website. There's a little about me section of who Dr. Schaberg is. He has quizzes. If you're junior staff and need some template comments, he's got great comments. And then he has his famous Kurt's notes. Without further ado, let's talk about liver frozen section evaluation. You get called by your organ sharing alliance and they have a donor and they're planning to donate a liver, and they found a recipient hospital that'll accept the transplantation. Now, we have to assess whether this liver is viable before they accept that transplantation. So we look for steatosis. There are two types of steatosis: macrovesicular, microvesicular. Macrovesicular is more clinically important. Histologically, you'll have single large fat droplets that have the nucleus pushed to the side with often smaller droplets mixed in. And causes include alcohol, MASH, metabolic syndrome, and you want to estimate the percent of total liver area involved, because if it's greater than 30%, that's a relative contraindication and they may not use the organ. If it's greater than 60% macrovesicular steatosis, that's an absolute contraindication and they will not use the organ, and it's associated with severe reperfusion injury. Microvesicular steatosis, you'll have these diffuse small fat droplets to the point where it has a foamy appearance. Kind of reminds me of a hibernoma, and it can occur following warm ischemia and does not seem to adversely impact transplant outcome. And then you have this term intermediate droplet fat, where you'll see occasional fat droplets of intermediate size that do not displace the nucleus. This is of no clinical significance. However, some people do include this microvesicular count, others do not. In addition to steatosis, you want to look for portal inflammation, fibrosis, and this is reported using a scheme based on the BATS and Ludwig system. Here in this picture, we see grade 1, which is minimal, and this is usually acceptable for transplantation. However, what is too much for transplantation is when there's inflammation grade greater than or equal to 2, mild, or fibrosis stage greater than or equal to 2, meaning the portal tracts have fine, irregular fibrous extensions that mostly don't extend between portal tracts, but rare bridging is allowed. And your differentials for these findings include viral hepatitis, autoimmune hepatitis, drug reaction. And Dr. Schaberg provides a great article on intraoperative consultation for donor liver biopsy. It's published by the Archives of Pathology and Laboratory Medicine and freely accessible. Lobular inflammation. So remember, the liver is broken down into 3 zones. Zone 1 is the portal tracts. Zone 3 is the central vein, and zone 2 is mainly your lobular inflammation is. And you'll have these hepatocytes outside of the portal tracts with associated lobular disarray, ballooning, and or acetophil bodies. And your differentials include acute viral hepatitis, drug reaction. Necrosis, you want to look for a coagulative necrosis. You'll have loss of cellular detail with minimal inflammation, and it often has a pericentral location. The common cause is shock, and of note, it's histologically identical to your acetaminophen overdoses. What is usually too much for transplantation? When you have necrosis greater than or equal to 10% of the liver area. Speaking of necrosis, a mimic of necrosis is saline artifact. Saline can cause edge tissue degeneration, where you have these shriveled pink hepatocytes. And it does look like necrosis, and your clue for saline artifact is this edge location. Saline can also cause cellular swelling and edema centrally. Lipofuscin, I really like this. This is a fine yellow-brown pigment. It's the senior freckles of cells that is often incidentally seen near zone 3 or central veins. It's a wear and tear pigment, although you see them generally more so in older patients. You can see them in kids and it has no clinical significance. Cholestasis. This is visible bile. It'll be yellowish, brownish, green pigment. It can be located in the canaliculi, the spaces between hepatocytes where bile travels, or within hepatocytes. It's always pathological. It can be seen in many conditions, not limited to bile duct obstruction, sepsis, drug reaction. Just a recap before we talk about donor kidney evaluation. Liver frozen evaluation. Look for macrovesicular steatosis, greater than 30%, greater than 60%. Look for portal inflammation, fibrosis, greater than or equal to 2, mild, or fibrosis stage greater than or equal to 2. Look for lobular inflammation. Look for coagulative necrosis and whether it's greater than or equal to 10%. Saline artifact, if you think there's necrosis of hepatocytes, remember, if it's at the edge and the hepatocytes are shriveled up, that can be saline artifact instead. Lipofuscin, senior freckles of cells. It's the wear and tear pigment, no clinical significance, whereas cholestasis is always pathological and can be located in between the hepatocytes and the canaliculi or within hepatocytes. The main purpose of kidney frozen evaluation is to evaluate for unrecoverable loss of renal mass or function, and that includes scarring such as glomerulosclerosis, interstitial fibrosis, tubular atrophy, chronic vascular disease, and rarely infarction. So let's talk about our histo in kidney. You have your glomeruli, and here is a section of normal glomerulus. You want to count the total number of glomeruli and the number that are globally sclerosed, and then calculate that percentage global glomerulosclerosis. Now, what is global sclerosis? It's when you have scarring or hyalinization of more than 1/2 of a glomerulus, and it's seen with both normal aging and with chronic kidney disease. And you also look at the capillary loops. It should be open and delicate. A pro tip: when counting glomeruli, divide the wedge biopsy into several areas with a dotting pen, and then count each area and then add them together. Arterial sclerosis. So here is a H&E of a normal arterial. You'll have endothelium resting on internal elastic lamina and muscle, and it's not terribly thickened. And in hypertension, normally the endothelium should essentially be on top of the internal elastic lamina and smooth muscle layers. With hypertension and aging, you have deposition of collagenous extracellular matrix and vascular smooth muscle cell growth between the endothelium and the internal elastic lamina, leading to thickening of the intima or intimal fibroplasia, and subsequently the narrowing of vessel lumen. And let's see how the intimal thickness increases based on the severity of arterial sclerosis. This is mild, this is moderate. So here are the internal elastic lamina and the endothelium. And this is severe. Again, endothelium, internal elastic lamina. Normal tubules, the proximal convoluted tubules are pink, fluffy, abundant, granular, cytoplasm, and they're close to one another. With freezing and saline transport, you may have lots of artifactual space between tubules versus fibrosis. Interstitial fibrosis and inflammation. Intimal fibrosis, inflammation, and tubular atrophy are seen together as part of nephrosclerosis, along with global glomerulosclerosis, and the fibrosis appears pink. And that contrasts with the artifactual interstitial fluid between tubules, because the tubules don't have tubular atrophy, nor do they have inflammation, and the artifactual clearing appears clear. And interstitial inflammation, the inflammatory cells are primarily lymphocytic, and you use a grade using provided cutoffs, which we will briefly cover. Acute tubular injury. This is when your proximal tubules, those pink, fluffy, granular cells, appear dilated and are lined by a flattened epithelium. The necrotic cell contents are shed into the tubule lumen and appear as fluffy, pink, granular casts, as you can see here and as you can see here. And it's often recoverable, meaning you could still give it to a recipient. Fibrin thrombi. You can see this in thrombotic microangiopathy, TMA, with platelet thrombi and fibrinoid necrosis in capillaries and arterioles throughout the body. And it's associated with donor head trauma and DIC. And you can see the fibrin thrombi here. It's often recoverable, and it's visible as homogeneous eosinophilic to red material completely filling blood vessels. Granular casts. These are muddy brown granular casts that are seen with acute tubular injury, and it's cellular debris and desquamated tubule epithelium. Granular casts can also be seen with other disorders. Parenchymal necrosis. You'll have coagulative necrosis with loss of nuclear basophilia. It may not be recoverable. So here's a good demarcation of that Dr. Schaberg provides a viable kidney with this parenchymal necrosis. You can see here there is no nuclei here in contrast to here. Diabetic nephropathy. Characteristic finding, as you've learned from med school, is your Kimmel-Steele-Wilson nodule, or nodular glomerulosclerosis, where histologically you'll see this large acellular nodules located in the intercapillary regions. And you often also see diffuse glomerulosclerosis. Arteriolar hyalinization. The vessel wall is thickened by a deposition of homogeneous eosinophilic material that's PAS positive on permanence. It is often hard to see on frozens. It's seen with hypertension and diabetes, and it narrows the lumen, leading to renal ischemia, leading to atrophy. And here is a sample donor kidney evaluation that you may have to fill out as the pathologist doing the donor organ evaluation. For a kidney, we'll look at the number of glomeruli, number of globally sclerosed glomeruli, the percentage, number of arteries. We'll assess the percentage of interstitial fibrosis, tubular atrophy, interstitial inflammation, arterial intimal fibrosis, arteriolar hyalinosis, which is defined mild, moderate, severe based on the number of arterioles, glomerular thrombi, acute tubular injury, and necrosis. And then here's a sample sheet for right and left kidney information, where you'll have the number of glomeruli sclerosed, percentage sclerosed. And here's a sheet for liver biopsy, where it could be a needle or a wedge. Ask for the fibrosis of some portal areas, most portal areas, up to cirrhosis of inflammatory cells are mild through marked, and whether there is centrilobular necrosis, lipofuscin, active lobular inflammation, cholestasis. So just to recap again, donor liver, steatosis, 2 types. Macrovesicular is more important. Portal inflammation fibrosis, you want to assess whether it's grade 2 or greater, or fibrosis stage 2 or greater. Lobular inflammation, necrosis, often pericentral. You want to see whether it's greater than or equal to 10%. Saline artifact, look for that edge looking necrosis appearing section. Lipofuscin, cholestasis, always pathological. Donor kidney frozen, look for glomeruli, find the percent that are globally sclerosed, which is the scarring hyalinization of more than 1/2 of a glomerulus. Arterial sclerosis, that's over time the thickening between the endothelium and the internal elastic lamina. Normal tubules, proximal convoluted tubules are abundant, fluffy, granular, eosinophilic. Interstitial fibrosis and inflammation are seen together. You'll have intimal fibrosis, inflammation, and tubular atrophy. Acute tubular injury, you'll have dilated proximal tubules that are lined by a flattened epithelium with necrotic cell content into the tubule lumen. Fibrin thrombi, you'll have homogeneous eosinophilic to red material completely filling the blood vessels. Granular casts, these are your muddy brown granular casts. Parenchymal necrosis may not be recoverable. You'll have this coagulative necrosis. Diabetic nephropathy, look for your nodular glomerulosclerosis. And then arteriolar hyalinization, deposition of a homogeneous eosinophilic material that is PAS positive, and it narrows lumen. Thank you so much for watching, and we'll see you on the next episode of Pathagonia. Bye.